Good afternoon and thanks for joining us. I'm Judy Simpson. When Governor Shumlin signed the Patient Choice and Control at the End of Life bill into law earlier this year, it gave Vermonters an additional choice at the end of life. The new law is one of many choices that Vermonters have when it comes to end-of-life planning. So this afternoon we've called on two experts who can help us understand the choices that we have as Vermonters. I'm joined by Cindy Bruzzese, who is the Executive Director of the Vermont Ethics Network, and Dr. Ursula McVeigh, who is the Director of Palliative Care Service at Fletcher Allen Healthcare and a professor in the UVM College of Medicine. Thanks so much for being with us. Cindy, let's start out with talking about the new law itself. What is the Patient Choice and Control at the End of Life Act?
This is, as you said, the law that Governor Shumlin signed into effect on May 20th of this year, and essentially it makes it legal for a terminally ill, capable adult patient to request and obtain a lethal prescription of medication to hasten their own death. And I should point out that the patient needs to make a voluntary request for that medication and be able to self-administer the medication.
Okay. And so, Dr. McVeigh, can you touch on some of the reasons why someone would consider physician aid in dying?
I think a lot of Vermonters are interested to understand more of this law, and that stems from a place that people have things that matter to them very much when they are at or close to the end of their lives. And when you ask people what's important, people don't want to suffer, they're worried about their family, and a lot of people don't want a prolonged dying process when they're at the very end of their life. And I think it's that concern and why people are looking at all of their options of making sure that when they are close to the end of their lives that they have control and that they can be comfortable and that they don't have to live in a state of suffering. I think that's why people are interested to hear about this option.
And so how does this fit in with other options that people have at the end of their lives?
We've always had great care in when people's goals are comfort, of using everything that we can to assure that people are comfortable and to provide a peaceful death. And people have choices of what their goals of care are. And even in facing a terminal illness, how someone's medical care is provided or what are the intent of the medical care should be intricately aligned with what the patient's goals, values, and priorities are. And so people have control over what is the intent of their medical therapy, what are their priorities. And of course, through the course of a serious and could even be a very difficult illness, people might have priorities of controlling their disease and also alleviating suffering. And there's a point in a serious illness where people's goals shift, and they shift towards not extending their life or not doing burdensome treatments, but may accept less burdensome treatments, or people might reach a point where extending their life is no longer a goal or a priority, and their goals are about comfort only and allowing death. And that is navigating a course of a serious illness, and people's goals change through time.
And
I was just going to say, and I think that in Vermont we're just so lucky to have skilled palliative care providers who I consider to be sort of the masters with a very large toolbox, able to help patients kind of think through what their goals are, understand what kinds of decisions they're likely to encounter as their disease progresses, and kind of help them paint a picture of these are the options you have available in terms of treatment, and this is how it will look, not just today after we do this treatment, but 2 weeks from now or 3 weeks from now. And is that still consistent with what you want to do? And that people can do trial courses of treatment with, skilled palliative care and hospice physicians, and then figure out, well, you know what, this isn't really working for me anymore. Now I think I need to shift. And I think folks like Ursula and the hospice teams that we have across the state are just tremendously skilled at helping people navigate that kind of bumpy road.
And everybody's so different.
Right.
So everybody reaches these different points at different times, if at all.
Right. But everyone's worried about suffering. And I want to just be sure that I am highlighting in the spectrum of palliative care, we work with people through all stages of serious illness. We certainly care for people up through to and at the end of their lives, but we can be helpful earlier in the course of illness. And the philosophy of palliative care is relief of suffering.
Let's talk a little bit about that, because I know we have a slide that we want to put up, and we can kind of walk through that and talk about palliative care.
So palliative care is specialized medical care for people with serious illnesses. The focus of palliative care is providing patients with relief from the symptoms, pain, and stress of a serious illness, regardless of the diagnosis. The goal of palliative care is to improve quality of life for both the patient and the family. Palliative care is provided by a team of doctors, nurses, and other specialists who work together with the patient's other doctors to provide an extra layer of support. It's appropriate at any age, at any stage of a serious illness, and palliative care can be provided along with treatments that are still directed at controlling disease, or palliative care could be the only focus of care, meaning when we're not trying to control the disease or trying to prolong life, there can be a plan of palliative care only, where we just work to control the symptoms of the disease and allow and prepare for a peaceful end to life.
Mm-hmm. And that's very much up to the patient.
Right. The patient determines their goals and priorities, and we work together with the patient's teams to help make sure that the medical plan best fits the patient's goals and priorities, whether that's extending their life or not extending their life.
And so, when should someone have that conversation with their physician about end of life?
I would say early and often. There's a phrase that someone had said to me a long time ago, which is, it's always too soon until it's too late to have this conversation. And it's very difficult to talk about end of life, to talk about things that maybe are worrisome or uncomfortable. But we never know when we'll be confronted with a serious illness or sudden accident that really changes the quality of our life and maybe even the length of our life. And so having conversations early with your physician, with your family, to talk about your goals, your priorities around your health care, the circumstances in which you would be willing to kind of endure some burdensome treatments because you know that once you got over that hump, you could go back to enjoying a really highly fulfilling quality of life, versus times where you think, you know what, I don't think I want to do that anymore. And having those conversations in advance of a crisis or critical illness is just so important.
But of course, you can always change your mind as well.
And people do all the time. Mm-hmm. So exactly, but thinking about it ahead of time and knowing that you can change your mind and you have options, I think gives people a lot more flexibility and the control that I think they're seeking so often around end of life.
Well, I think, you know, for someone like me who sees people and friends and family members struggling through end of life issues, or maybe really ill, or maybe in a lot of pain, and I say, oh, I don't want that to happen. But Ursula, you mentioned earlier that there's something to be learned through going through that.
It really is the individual person that determines what brings their life meaning. And there are illnesses that have a large burden of physical discomfort that somebody may tolerate and may be able to find meaning and value in their life despite that. And it's hard to, I think people sometimes look at somebody with a really devastating illness and from the outside might think, if that was me, I wouldn't want that. Mm-hmm. But you really never know until that is you. And people do adapt to difficult circumstances or adapt to a quality of life that they wouldn't have thought was acceptable to them. And so that's where having conversations about where are you now? What are your goals of care now? Because there is a point where the burden of suffering, especially as people get close to the end of their life, that burden of suffering may overweigh their desires to extend their life, such that it's not an uncommon thought to be thinking about, I wonder about hastening death, or I wonder about allowing death. And so it is people's goals and values change, but it's hard to look from the outside to say, if that were me, I don't think I would want to do that, because people do adapt and find meaning despite very, very tough illnesses. And that's where in palliative care, we just make sure that, are we doing the best that we can for what are your priorities, and what do we have control over, and what don't we? And when you look at your life and what you need to be doing to feel like you are as much of who you are despite this illness, and are we doing our best to serve your priorities? And sometimes the priorities are tolerating a degree of physical discomfort or persevering despite that, because there's still meaning or value in living one's life. And then there's a point where that burden outweighs the benefits of extending one's life, and that's where the transition to focusing only on palliative measures, as opposed to palliative measures and disease-directed therapies and allowing death. But that transition of living with a difficult illness to dying from a difficult illness frequently occurs so fast. Mm-hmm. So that's why, as a palliative care physician, when I hear people's goals about not wanting to linger at the end of their lives and wanting to be sure they don't suffer, in my practice, I haven't felt like physician aid in dying is this tool that I haven't had to be able to achieve those goals. I felt like the biggest barrier to achieving that is we're not having good conversations about what are your priorities and are we meeting them.
Are patients surprised to find out that they do have a lot of choices?
I think they are. I think it's because culturally we don't really talk about it all that much, and what we see around end-of-life care and how things work is kind of what happens on television programming, which isn't really all that close to what it looks like in real life. And so I think that people are surprised when they find out. And I mean, how many times have I heard someone say, if I'd only known about this sooner, I would have gotten on hospice way sooner if I'd only known about this, or if we'd only known we could have had this level of support. And I think that people are surprised, and maybe that's the silver lining in this new law, is it's really brought to the forefront the idea of having proactive, disease-specific conversations about end of life and what this might look like and what my options could be and what would it look like if I chose to do more treatment, or if I didn't, how would you support me if I chose not to do this kind of treatment and allowed a natural death, how would that look? It really has prompted, I think, a lot of discussion, and that's a positive thing, for sure.
And so from a physician standpoint, how do you respond to a patient's request if they were to come and have that request?
What I have found, and this is still, physician aid in dying is new to me and to all physicians in Vermont, but I have found that when patients open that door and they ask about it, they can be at different stages of illness. It might be somebody who's not facing the end of their life now, but they're just interested to know about what this means. Or they might be facing an illness that will end their life, and they're not at a point where their plans might be to still be preventing death, but they're thinking about it. There might be a point when my suffering is too great, and they want to be sure that they don't suffer. So I'm always pleased when people open any door to talk about what matters to them at the end of their lives, because if we don't know what matters, then we run the risk of not achieving for what would be a good death on their terms. And the only definition of a good death that matters is the patients and whoever they think the definition of their good death matters to them. So. But people, when they're asking about that, mostly I ask, what is it that you're most concerned about when you think about that? And that's another door that opens. And then knowing what people are worried about. And also I want to get a sense of, do they think they're suffering now? Or are they thinking that if this goes on much longer, I don't think I could take it? Because maybe there's something that we could do now to alleviate their suffering while they're living with this illness. And it might be also that people are at a place where they are ready that their life come to an end, or they want, and a lot of people do ask this, some people do have an intent where having the control of the timing of their death and taking a medicine and doing that on their terms, that this is, that physician aid in dying best achieves that for them. But a lot of people don't realize that they might be thinking, I wish death would come, or people tell me I go to sleep at night and I just wonder, why isn't God taking me? And those types of thoughts of being close to the end of life and feeling like you're ready to die, or feeling like death's acceptable, there's a lot of ways to navigate that. But certainly we want to make sure people aren't suffering while they live with a serious illness, and we don't want people to suffer at the end of their lives. And there's a lot of ways to achieve that.
Because there is a lot of living you can do while you're in the final stages of dying, I suppose.
Oh, sure. Yeah.
Absolutely.
Yeah.
And now, Cindy, why don't we, you've put together a list of resources for people who want to get some more information about this topic or find out resources that we've been talking about.
Sure. There's a variety of resources that are listed on the screen. The first is our website, the Vermont Ethics Network. There's a website there as well as a phone number that folks can go to get more information about ethics and end of life and decision making, as well as about Act 39.
And if they don't have a computer, you're more than willing to send things in the mail.
People have called and said, I don't have access to the internet. Can you print this material off and send it to me? And we're more than happy to do that. The Department of Health, Patient Choices Vermont, and Compassion and Choices, those are 3 different places that folks can go to get information about, specifically about Vermont's new law, Act 39. And then I also have a website up there called starttheconversation.org, and that is another resource that folks have available to them to really find out more about the hospice and palliative care services that Ursula was referring to, that are available to patients to learn more about what's out there. Which
is important because a lot of information, and it's a good way to sort of start the conversation if you haven't already with your family, because it's something that really people should be considering.
Absolutely. It's, as I said, it's never too soon to have the conversation, but when you're in the throes of a healthcare crisis, it's tough to be doing it then.
Okay. Well, I want to thank you both for joining me today.
Thanks for having us.
Thank you.
That's our program for today. Thanks for joining us. I'm Judy Simpson. I'll see you again next time on Across the Fence.
For a video copy of today's program, call toll-free 1-888-ATF-3430. Across the Fence is brought to you as a public service by University of Vermont Extension and WCAX TV.